Welcome everyone. This is Dr. Sharad Jaitly from New York, your cardiologist on your favorite website, MuniMeterHealth.com, which is dedicated to teaching you about the human heart and its illnesses throughout the globe and on our social media channels. So welcome again. Without any further ado, I'd like to delve into the subject matter on MuniMeterHealth.com, and thank you for associating with us. Today's subject is SVT, which is Supra-Ventricular Tachycardia. Now, it's also called PSVT because they are, why? Because they are paroxysmal, and therefore they are called paroxysmal supraventricular tachycardias. Now, just to define, there are three types, quickly delving into the facts. Let's do that. One is Avnrt, and the second one is Avrt, and the third one is AT. Now, let me just elaborate that. Atrioventricular nodal re-entry tachycardia. So atrioventricular nodal re-entry tachycardia. Here it incorporates the node, the AV node itself. So AVN is the AV node. The atrioventricular node is incorporated within the re-entry variety. So remember that. So it's an intranodal. So we'll write intranodal. Avrt, which is atrioventricular re-entry tachycardia, does not involve the node, but it involves therefore something else, and it's called, it bypasses the node, therefore we call it bypass tracks, or pre-excitation pathways can be involved. And atrial tachycardia is typically atomicity, where a group of atrial cells just get together and start doing the re-entry mechanism. Sometimes it is also related in congenital heart disease, for instance, and or post-op cases as well. One sees that also. Now, intranodal has the highest percentage, so 60%. This is roughly about 30%, and this is approximately the remaining, which is we call 10%. So those are your three varieties of supraventricular tachycardias, or PSVTs as we sometimes call them. Now let's elaborate on Avnrt, for instance. Now we'll go to Avnrt and define exactly where the pathways are and where the problems are. Now remember, Avnrt is again of two types. One is typical, okay, and the one is typical, so the other one will be atypical. Very easy so far. So the typical variety obviously is more common, and that's easier to diagnose. Why? Because we'll just tell you that in a second. So here's your schematic, my favorite heart that I normally draw. Here's your right side, and this is your left side. So most of the pathology is on the right side because that's where the conductions are happening. So if you will, now let's see, we'll draw the SA node here, the AV node here, for instance, and down is the bundle of His, and therefore the Purkinje fibers, and the conduction normally occurs in this fashion. Okay, so we'll show the conduction like this, and then it goes down like this, as well as like that. It's okay. So, and then it retrogradely conducts and activates the ventricles. So the whole idea is that is being utilized, and in Avnrt, if you will, it is the node, the AV node, that is taking the re-entry mechanism. Why? Because you have, imagine the re-entry mechanism like as if it's going in circles within the node itself. So what is happening is, let's elaborate this, for instance. So if you elaborate this, you will see the following. This AV node, we are drawing the same AV node just from here, we are drawing it here. And when you draw it, you'll see the anterograde conduction is slow, but the retrograde conduction is very rapid. We are showing with two arrows. So what is happening? You will have the atria quickly getting activated. The ventricles are slowly getting activated, normally getting activated, but the atria are quickly getting activated. So what will happen to the RP interval? This is the R, for instance, and this is your P. So the RP interval is going to be short. Or in fact, it could be even superimposed. So we'll say superimposed. Okay, I'm writing it very hurriedly, but you understand. RP is short, and especially on a surface EKG, you'll see that the QRS, like this is normally your PQRST. In a setting like that, what will happen is you'll have a QRS, and the P will be right there on the top. Or sometimes the P could be hidden here. So it could be either here or here. Now, the second variety that is going to be is the atypical variety, if you will. And we'll draw the atypical variety just underneath, as a matter of fact, right here. For want of space, I think we're going to make the heart looking a little smaller here, because we need to discuss the other part as well. So when you draw the heart in this fashion, What you're seeing is, again, SA node, AV node, and then the retrograde conduction like this. So this way, automatically, the re-entry mechanisms or normal activation also, if you will, has occurred. So the atria contract, and then the ventricles contract to the bundle of His, and then the Purkinje fibers. So now you have the same node here, for instance, and this node we are looking at, we'll draw in the same color as a matter of fact. So this node is now participating the following way. How is it participating? Let's look at it. We have the node, and this time it is participating in this fashion. That means rapid conduction, but a slow retrograde conduction through the node. So what is happening is the ventricles will quickly activate, but the P wave will be long, will come in later. So here you have an RP which is long or elongated. So this is an atypical variety, and it can be again seen on the ECG. So the normal PQRST, for instance, here. But then the complexes here would appear like you'll have a QRS, obviously no P wave, T wave, and then could be a P wave here. So you see how the R and the P is prolonged. So R and P are prolonged here in the atypical variety, whereas in the typical variety, the RP is extremely short and superimposed. Again, these are just manifestations on EKG, but one should know how many types of AV and RTs do occur, because this will definitely be on the boards, and these are, again, narrow QRS tachycardias. They will constantly be treated in a similar fashion, more or less, in general. Now, let's understand the second variety, which is AVRT. So we have done one. Now let's do the AVRT. What is AVRT? These are utilizing the bypass tracts because they are atrioventricular re-entry tachycardias, and they are occurring the following way, if you will. So here we're going to draw the same schematic all over again, and quickly showing you that the SA node is existing here, the AV node is existing here, and then the bundle of His and Purkinje fibers, which we don't want to show, but they are automatically the conduction in this fashion. This is the normal conduction. Now, quickly to go over that, there is a bypass tract which is existing. Now, here is the bypass tract. So the bypass tract is existing. So when the bypass tract is anterogradely conducting, which is the normal way, it'll cause a delta wave. Why? Because the QRS will not be normal in this setting. If the QRS was being, say, the ventricles were being activated through the normal conduction here in this fashion, you would not see a delta wave. But when you see a delta wave, that tells you that there's a bypass tract that is being utilized for anterograde conduction, and then the retrograde conduction is through the rest of the fibers here. So basically you're having a re-entry mechanism which is involving the bypass tract. So delta wave is seen, so it's called the manifest variety. This is the manifest variety of AVRT, also called as WPW syndrome, Wolff-Parkinson-White syndrome. And why is it called a syndrome? Because it's manifesting as a delta wave. It can be seen. It normally presents with SVT, and then the classic QRS prolongation will occur in these settings. So the PR is extremely short. Why? Because the PR will be very, very short here. So PR is short. There is a QRS which is prolonged, obviously, and then there is a delta wave. And in addition, you should have some SVTs, that means supraventricular tachycardia, or atrial fibrillation, sometimes even atrial flutters or atrial arrhythmias will occur in these settings. Okay, so this is the manifest variety or the WPW variety. The second variety of the same AVRT that exists is where you have, let's draw the heart quickly again. And for want of time, I'm going to draw it rather quickly here and going over the SA node in the same fashion, using the same color codes if possible. Yes. And then you have, even though you have the accessory pathway in this direction, but what is happening is it is conducting via the AV node first, and then it goes a little slower, but then it retrogradely goes over the node. So this here, you will not see the delta wave. Why? Because the QRS is normally present. So no delta wave. Delta wave is not present. Here the delta wave is present, and this is the concealed variety, if you will. Concealed pathway. Here you cannot tell if the WPW is being utilized because it's concealed and you don't know the delta waves existing. But regardless, the treatment will more or less stay the same, and we'll talk about that in a second with some minor variations. Atrial tachycardia, remember atrial tachycardia, we can draw it right here itself in one of these things. Here you have a group of cells which will become re-entry, which will develop a re-entry mechanism, and they lead to atrial tachycardia. So we have covered all the three varieties of our arrhythmias that we just talked about, the SVTs in atrial tachycardia, where there is an atomicity, Avrt, which is the bypass tract, not utilizing the AV node within the node itself. That means the re-entry is through the bypass like we just showed you, and the Avnrt, which utilizes the nodes per se. So the node has its own re-entry mechanism, a slow anterograde mechanism, and a retrograde very rapid mechanism. So R for R. Okay, so having understood that, and the distinguishing features on the EKG, like I just showed you on the surface EKG, the delta wave will be present in the manifest variety, which is WPW syndrome, and a concealed variety will not show a delta wave at all. Now, having shown the atrial tachycardias, as I said, the P waves will be seen mostly in the leads V1. So you will see in the lead V1 there will be a P wave. So V1, that's a diagnostic. The rest of the 11 leads will not show the P waves because P waves are best seen in V1, and normally they are upright, and that's an atrial tachycardia. Now, what is the treatment plan? Very important, right? We are getting to the treatment plan. Well, the treatment plan immediately consists of start with IV adenosine. When these patients present with PSVT, remember, once you have diagnosed that on the ECG, PSVT on ECG, I would give 6 to 12 milligrams of adenosine, and 95% of the times you will be able to convert them into normal sinus rhythm. Okay, it's the other 5% where you have to worry about, obviously, and that's where you'll see it's the atrial tachycardia which will not respond. So first, having ascertained that these are narrow QRS complexes and they are PSVTs, remember, narrow QRSs, you will give IV adenosine first, and you will tell and warn the patient, because the patient is relatively awake at the time, even though maybe lethargic or maybe pre-syncope manifestations or lightheaded, etc. Tell the patient you're going to feel a little uneasy for a few minutes, or not a few minutes, for a few seconds, maybe like 5 to 7 seconds, because adenosine, the half-life is only 11 seconds. Remember, the lambda is only half-life is only 11 seconds. So you will warn the patient that you will feel, and because there is a sudden abrupt termination of the arrhythmia. So the patient will, and then restoring back to normal sinus rhythm. So you will feel, the patient will feel. The second modality you can use is IV beta blockers. You can use IV calcium blockers, if you will. And then cardioversion is very, very important. Cardioversion is the procedure of choice, specifically so if they are hemodynamically unstable. If they are hemodynamically unstable, use the cardioversion as the procedure of choice. Now, long-term management is obviously RFA, which is radiofrequency ablation. Why? Because you have a 90% success rate, 90 to 99% as a matter of fact, sometimes. Success rate depending upon the groups of the referral centers who are practicing it, and it's a low risk, so the complication rate is extremely low. 90 to 99% success rates will be present, and so that becomes the procedure of choice specifically for the long-term management. For acute managements, of course, you'll start with IV adenosine and straight go to cardioversion. The only contraindication, now here's the caveat: do not use beta blockers. Do not use no beta blockers. No, as I said, no. Is no beta blockers, no calcium blockers, and no AV nodal blockers, if you will, in the setting of WPW. If you have a WPW, do not use this. No beta blockers, no calcium blockers, and Avrt. Why? Because WPW can degenerate into atrial fibrillation then at that point, and that's a life-threatening arrhythmia. It will be very, very rapid arrhythmia, and or sometimes even into VF, and sudden cardiac deaths have occurred. So you do not want to block the AV node in a setting of a delta wave. Remember, you do not want to block this AV node totally by a beta blocker or calcium blocker. Specifically, if you see a WPW syndrome, do not use beta blockers or calcium blockers. You can use amiodarone, you can use other drugs if you need to, have to do drug, but otherwise tend to use cardioversion. That will be the better way to really convert these patients. And then, of course, radiofrequency ablation as a long-term standing therapy, which has the highest rate for WPW as well. Okay, so just be mindful. Atrial fibrillation can precipitate in a setting where if you use beta blockers or calcium blockers in a setting of WBW, and if the atrial fibrillation is already existing, then that's a total contraindication, obviously. Then that's already manifesting as atrial fibrillation with a rapid ventricular rate in a setting of WBW. You've already clinched the diagnosis as is, so then also it is obviously total contraindication. So radiofrequency ablation is the long-term management, and of course cardioversion in the acute setting when the patient is hemodynamically unstable. Okay, thank you so much for your attention on MuniMeterHealth.com. This is your favorite website, and we try to give you short video vignettes, primarily to make sure that you understand them and use them for your boards, for your exams, and of course for your clinical day-to-day practice. And I welcome all my residents, interns, fellows, colleagues, and medical students and trainees to associate with us and give us the support so that we can spread this knowledge even further to the entire corners of the world. And it's again freely available to all of you. So please join us and bring all your colleagues and all your students and residents and fellows to join at MuniMeterHealth.com. And if you do like it, press the like button, because I really welcome that. So this way we know exactly you and I, we are in communication via online. And of course, your comments, your suggestions, your questions are always welcome. Thank you again. So long. This is Sharad Jaitly from New York. Bye.